Teizeem, welcome to the podcast. We're so happy to have you here.
Hi, thank you for inviting me.
Amazing. Meg and I have both worked with you with shared clients, so we know just how incredible you are. So we're really, really happy you're here. To start us off, would you mind introducing yourself, your role as an eating disorder psychiatrist, and kind of what drew you to this field, specifically working with eating disorders?
Yeah. So maybe I'll start just saying a little bit about myself so that
Yes,
people
please.
understand, what's the difference between a psychologist and a psychiatrist, because I think this is a
Mm.
question that I get asked a lot. Um, and I'm always surprised that how many people don't know the difference, and then that can be really hard in terms of knowing who do I need to see. So yeah, definitely one of the so when in terms of training as a psychiatrist, um, I first went through medicine as my degree. So I did the kind of 5 year training in medicine, became a doctor first. And so you become a medical doctor, you then do all the kind of medical training that you would do for a couple of years. So things like respiratory, cardiology, surgery, all of those things. And then that's when you decide what specialty you want to do. So I decided that I wanted to do psychiatry. I had a couple of jobs in my training that I just found were fascinating jobs in psychiatry. And so that's when I decided to specialize. So the specialization takes around 6 years. You do 6 years of 3 years of general psychiatry. So that could be adults, child, learning disabilities. I did forensic in there as well. And then you decide what you want to subspecialize in. So I went into child and adolescent psychiatry. And as I was doing my training, I guess I just became really interested in eating disorders. So I ended up doing some time as a special interest in Great Ormond Street Hospital, and also a hospital in North London in their eating disorder service. And then I decided that this is definitely kind of like my special interest and what I wanted to do more of. So then after the 6 years, I became a consultant. Actually then went back to the North London Hospital and got a job there as a consultant in their eating disorder service. So that was outpatient and like a day patient service. And I was there for about 4 years before coming to the UAE. And I've been here around 5 years. So the difference between psychology and psychiatry is that we're obviously medical doctors, which means that our role, and particularly in eating disorders, is quite specific and different. So when I first assess a client, one of the things I'm really thinking about is their physical health and their physical health risk. So we would do a full assessment in terms of the effect that the eating disorder is having on them physically, because we know it's not just a mental health illness. It doesn't just affect the psychology of the brain. It also affects their heart, their periods, their bones, lots of different, all systems of the body actually. So that's one thing. The other thing is actually making sure that there aren't any underlying mental health difficulties. So I'll give you an example. When I was in London, there were a couple of clients who would come into the service and it just didn't fit a picture of an eating disorder. So there was one client particularly who was referred from the hospital. She had vomiting. She was also she was vomiting, she had low weight, and she had no interest in food or eating. So, normally I think it was an appropriate referral where you would think possibly there's an eating disorder. Something just didn't fit. I think the body image disturbance wasn't quite as strong as we would normally, think it would be. And so we actually got her to go back to the hospital and have some more tests. And it was like when you have that sort of inkling that something isn't quite right. And it ended up that she actually had a brain tumor. And that was the reason why she was vomiting, and why she had lost so much weight. Another child had come in, similar kind of pattern. It ended up that she had celiac disease, which is an inflammatory bowel disease. So again, these are things that we're thinking about when we're assessing a child. Is there something else that could be going on? A lot of risk management, thinking about, comorbidities. Do they have an underlying depression, anxiety, autism, ADHD? Is there something else going on that could be adding to the picture or that might need treating? And then also medication, I guess, is something, and I know we'll be talking about that today.
Wow, fascinating. So interesting. What a long journey it takes. I actually did not know that. That's incredible. What was it that actually drew you specifically to eating disorders? Did you see a change in your patients? How did you know that was the right path for you?
I think, eating is such a big part of life, or it has been a really big part of my life. I think,
Mm,
socially, family gatherings,
mm,
celebrations. And what I was seeing is that it really affects family systems.
mm,
And in my child training, I actually did a postgraduate in family therapy, systemic family therapy. So
mm,
already I was really interested in family changes, how communication in families and things like that. So I think it just you know it it just broadened my interest in terms of like how families work in a patient who might have an eating disorder, and how all the changes happen, how food becomes a central part of all of this. And then the other thing, I guess, is, out of all of the mental health disorders, because of the physical aspect, I still get to kind of hold my medical hat to a
mm.
certain degree. Which again, it means that that I'm doing both. I'm thinking about the psychiatry, and obviously, and I do see other, I see other mental health disorders. I first and foremost, I'm a child psychiatrist, so I do see everything. But I think eating disorders has just, been something I was very much interested in.
Incredible. Thank you.
Out of interest, then, your sessions in a week. So I've seen a psychologist, and I understand I go for like a 50-minute talking therapy where it's me and the psychologist one-to-one talking. How do you practice? Like, do you do that as well? Like you're saying, it's not just prescribing medication. Like, do you kind of do a range of different things with people?
Yeah, so it really depends. So a lot of one thing that a lot of people don't know is that psychiatrists also tend to train in different therapies. So because eating disorders was my passion, I also am trained in CBT, so that's cognitive behavioral therapy for eating disorders, and also family therapy for eating disorders. So I have a mix of clients who I'm seeing, as the primary clinician, also doing the therapy with those clients. And then I have clients who I will consult on, and who are also seeing other members of the team, a dietitian and maybe a psychologist. So, and that's really important, having that multidisciplinary team. So in terms of my work, like all of our assessments tend to be 2 hours, because we need that amount of time to understand the background of what's been happening, talk to, as I'm seeing children, so I spend time with the young person. I also spend time with the parents. We want to make sure that when somebody comes for their first appointment, they don't just leave having kind of told us their story, but they leave with a plan, and we have time to kind of educate them about the diagnosis, if it is an eating disorder. And we can really think about, what school's involvement going to be, what medical tests do they need to have. So the initial assessment would always be 2 hours. And then I would do the normal kind of 50-minute sessions with them for therapy. If I am just consulting and I'm seeing them for medication, depending on if they're kind of established on the medication or not, then we would do half-an-hour reviews. So that gives us a chance. And that's really, we'll talk about it later, but I think that's really important in terms of when somebody goes on to medication, that the monitoring needs to be really robust. So it's really important, because that monitoring for the person, for the client, means that they have someone to be able to talk about, what's working well, what's not working, do changes need to be made? Because I think sometimes people will go onto medication without having that close monitoring, and then they don't have a satisfactory response, or they don't feel satisfied with the, their kind of expectation versus what the medication's actually doing. And that could be, through discussion, resolved either by thinking about dosage or changing medication. So that monitoring is essential. So if I was to ever start anyone on medication, it would always be with them knowing that monitoring is going to need to happen.
Mm-hmm. Yeah. Thank you. So, slight change in topic. We would like to talk to you about the rise in weight loss drugs. And how it's kind of like all across social media generally, and the impact you're seeing on your clinical population. And like thinking from my own experience when I had an eating disorder, I don't think it would have been as in like the drugs are out there, I should take the drugs, but more just the attention on weight loss and how it's being even more kind of glamorized, and also it's more easily accessible. So it's kind of like promoted more, like it's a good thing, it should be happening, lots more people are doing it, that kind of thing. I think just the general noise around weight loss would have been really difficult for me. So have you been seeing this with your clients? Is this something you've been discussing?
Yeah, absolutely. And I think you hit the nail on the head with all of those different points. So I think the first thing is that it's so accessible, and it's also not very well regulated, right? So people are having access to these drugs without seeing a doctor, getting it from a pharmacy, getting it online. And so firstly, it might be that they actually don't need the medication. They don't have underlying insulin resistance, they're not diabetic, there is no risk there. So one, it's accessible, and then it's not regulated. That means lots of people are getting into situations where, particularly if there is an underlying eating disorder that either they haven't known about, or maybe they do have insight into it, that they're going onto these medications, which might then result in them experiencing not only the side effects of the medications, but actually worsening of the eating disorder, worsening of the side effects. They're more prone to them, right? So the point of the medication is to reduce your gut motility, reduce your appetite. That is going to add to starvation syndrome. It's going to add to the problems that you experience with gut motility. And so it's actually really risky because you're doing two things there in terms of, it's the eating disorder, but it's also then the medication. You've got the side effects of both. So I think that's, one particular thing that we want to be really careful of. Because if we imagine that normally people who might be overweight and for medical reasons need to go to have some support, and maybe they're going to see like a bariatric surgeon or something like that, for instance, there is always that regulation in terms of like an assessment, or there should be an assessment of an underlying eating disorder. Whereas if this isn't happening, someone could go on the injections at the time when they either taking the medications, things are worsening in terms of their eating disorder, but when they stop, it might actually cause the opposite effect, which might mean that they enter into, for instance, binge eating, or that they are unable to kind of maintain some of the weight loss that they've got through the injections. So I think those things are really important. You talked about.
Can I just say one thing in that? I'm so glad you've said that, because I feel like it's painted as like a golden ticket to weight loss. Like it's just like you can lose weight, but like no one talks about and develop an eating disorder in the process. It's almost like seen as a sidetrack around, oh, diets were so difficult, restriction is so difficult, it comes with like social isolation and eating disorder thinking, blah, blah, blah. But that to me is never spoken about with weight loss medication. It's literally painted as like this golden ticket to do it problem free.
Yeah. And it's also that wish for a quick fix, right? We all want a quick fix for anything in life, right? We're trying to make this sort of effort to get to where we need to get to is difficult. But then that's the whole point. The whole point why diets don't work is because you go on a diet, you lose the weight, it's not sustainable, it's not a lifestyle change. And so what that means is that you'll then sort of, the behaviors from before will creep up, but you'll gain the weight back, if not more. And that's the same with any of these weight loss injections, that you'll gain the weight back, if not more. And if it doesn't, whether or not it creates an eating disorder is an important thing as well, because actually if people are losing weight quite quickly, quicker than they should be, or more than they should be, there's a risk there to enter in starvation syndrome and then develop an eating disorder, even if there isn't an existing one. And one of the things you said about society, like the societal pressures, is that it's just exacerbating that, right? In terms of this idealized thinness and the appearance ideal. So actually, it's really, really hard. So for people who either have an eating disorder or just general people, we all then are left thinking we're not doing enough. We don't, we're not good enough because of the fact that there are so many people around us who might be on these injections. I'm sure everyone would be able to name one person that they know that has been taking either Ozempic or Mounjaro or Wegovy. And that's quite scary, to be able to be living in a society where actually you're constantly feeling like you're not doing enough or that you're not looking good enough.
It's a lot of pressure. It's a lot of pressure and a focus on the wrong things in life. Again, focusing on comparing with bodies and food and size, when really it's about values and the person you are.
We'll be back to the episode in about 30 seconds, but first we want to invite you to our Rewired in Action community. If this podcast helps, but you'd like more support, practical tools and answers to your questions from us, we'd really love for you to join.
We created this community because we kept hearing from listeners that it's so hard to hold on to motivation. Even when you really want to recover and you're sick of living in Groundhog Day, it's so hard to make that change in a moment. We know exactly what that feels like, and that's why we made this community for you, the one we wish we had in our own recovery to help you break the eating disorder cycles that are keeping you stuck.
We meet twice a week on Sundays and Thursdays at 5 p.m. Dubai time, and all the sessions are recorded so you can catch up if you need to. That means that no matter what your time zone, you can still join, and in fact, lots of our participants rewatch the sessions a few times during their week.
It's anonymous and listen only. We know how important it is to have a safe space without comparison or triggering details. Our members span 5 decades of life at many different stages of recovery, so whatever your age or stage, we'd love to have you.
It's not a replacement for therapy or treatment,
but it is consistent, practical, compassionate support that really helps people make meaningful change in their recovery.
You'll find all the details in the show notes, and we would love to support you.
All right, now back to the episode. Another area that kind of comes up quite a lot, Meg and I have a community, and a question that's popped up quite a bit in our Rewired community is around clients or members who identify as being neurodiverse. And they have asked now, how does that impact their recovery, having either maybe ADHD or autism? Are there extra challenges when you have an eating disorder and you identify in that way? Is there any specific strategies that you offer to your clients as well that would support them, whether that be around making sure they have their meals on time and that sort of thing?
Yeah, so we do see a lot of clients who might have neurodivergence, and that might be pre-existing, it might be undiagnosed, or it might be that with the starvation syndrome, it feels like symptoms have come up that look like either ADHD and autism, but actually there isn't an underlying ADHD and autism. It's just that they're so starved nutritionally that they appear to be, losing focus. They're more restless. They're more anxious. They're more unable to kind of remember things. Yeah, the fasting effects, or also very kind of rigid in their thinking, black and white, right? So some of it is the starvation syndrome. But if there is an underlying or an undiagnosed ADHD or autism, it also relates to the disorder, by the way. So, for instance, you're more likely to develop, so ARFID is seen more in people with autism, for instance, whereas people with ADHD might develop things like binge eating disorders because there's the impulsivity in the binging. And in some ways it's like a coping mechanism. So you might also see some variations in diagnosis. I think in terms of treatment, we want to kind of think about, is there a need to treat the underlying neurodivergence? So if it was ADHD, would giving them medication help, or would it actually hinder the eating disorder? So I've often seen people with ADHD who go on to medication and then later develop an eating disorder, because what happens is that the medication can cause them to lose their appetite. They don't eat enough, they lose too much weight. And then if you also have body image difficulties, and there's been other things, trauma, bullying, conversations around the dining table at home, frequent weighing, things like that, then all of those things are risk factors that might mean someone who is simply just being treated for their ADHD actually then develops an eating disorder. There's so many things to think about there. So we would always tailor our treatment in terms of what the client is bringing and what the difficulties are. So for someone with ADHD, you might do more of writing things down, helping them to remember things by either putting alarms, so being able to prioritize the eating and the timings of their eating. They might need more scaffolding from parents. If they're adults, then maybe they need other people to kind of help them and support them, partners, for instance. You want to kind of think about what behaviors are impacting on the eating disorder. So if they are very impulsive, are there any other coping skills that they're using? Sometimes we see a lot of substance misuse as well in people with ADHD. So thinking about those things. And I guess, in the treatment, you just want to, I guess the challenges are that they might find it really hard to do the planning part. And so you might focus more on the planning and the organization with them in the therapy. And I think for autism, I think the challenges there are often about rigidity. So often they're quite black and white in their thinking. They have sort of difficulties being able to kind of see the bigger picture sometimes. And so that can be really hard in terms of seeing future goals or motivations that you might have. Sometimes people with autism might have more of the obsessional thinking, and that might be something that you're working on in the therapy. And sometimes actually it can be a huge advantage. So, because change can be difficult, and actually routines are something that young people with autism tend to kind of move towards wanting routines. And so you can actually use that to your advantage by sort of thinking about how do you use that in the treatment with the like meal planning and keeping things consistent. I would say some of the challenges will come up will be things like textures to food, smells to food, not being able to kind of have different varieties of food, maybe more bland and sort of white foods. And so you might do more exposure work in the therapy as well for people with autism. So it's definitely something that we think about when we're doing the therapy, and think about all of those different facets.
Is it difficult sometimes to tease apart like what's driven by the eating disorder, what's driven by other things going on, what's driven by your brain wiring? Do you know what I mean? Is that a difficult kind of puzzle to pull apart?
Yeah, it can be. And I think that the easiest thing is to be able to do a really good history and timeline. So we will often do like a developmental history with parents. So this is if there isn't a diagnosis already, is that we try and think about when did the symptoms start? So when did they become more rigid, or when did they start to lose more attention and become more impulsive? Was this after the eating disorder, or was it before? Were the symptoms when they were a young child? And, how were they at school? What would the teachers often sort of write about in their report card? And so by doing a good timeline and a good history, that gives us the information to let us know, how is this to do with starvation, or is this to do with something that's underlying? And I think a really good test, or obviously, you'll hear this so much, that food is the medicine. So actually what we often see is that when people are weight recovering and they get more nutrition, that some of those cognitive changes that you see when they're kind of early on in their illness, that they really significantly change. And you can see it, you know, people will say to us, and we see it in the therapy, they're more engaging, they're more spontaneous in their speech. Their affect is much more kind of wide and open and expressive. And people will say, oh, I can think clearly. I wasn't able to kind of, everything was really foggy before.
Yeah, even like behaviors with food, I imagine, like needing certain routines and structures and things on the plate, that kind of thing. And then, like, I certainly experienced this. And then one day I just kind of didn't need to do it anymore. Like, as I was getting better, I kind of just naturally lost. I mean, I've never had a neurodivergence assessment. I have no idea. But a lot of the behaviors I did have in starvation just spontaneously recovered.
Yeah, absolutely. And so some of those things, if they're not recovering, then, and despite, you know, everything else getting better, then that might sort of give you more of an indication as well. We would never do an assessment for ADHD or autism when somebody is really underweight, because actually, you know, if they have ADHD and they have autism, it's something that they've had all their life. So, you know, doing an assessment right when they're in the mix of things being really difficult doesn't help, and it might give you also false results. Right. So we would also always wait for a bit of weight recovery to make sure we get a better assessment.
Okay. Thank you.
I have one more question. Sorry, I find it so interesting.
Yeah, it's so interesting. Yeah.
It's part of it as well, just getting to know yourself and like learn your brain and how you operate kind of thing. Because like you said, if you've got underlying impulsivity, even if you take the behaviors around food away, do you then have a propensity to turn to something else, Like, do you kind of need to learn healthier coping mechanisms in replace of whatever you've been using with the eating disorder?
Yeah, because often lots of people will say that, you know, there's a function for the eating disorder. It came at a time where it then ended up serving a function. So either there's some chaos or distress or underlying anxiety, you know, something that has happened that has meant that the food was the way that they coped, because that will numb feelings. It will kind of numb your emotions. And that's actually a really helpful tool, right, at the time, because it means that it's serving a function. But if, for instance, if that impulsivity is something that was there from before, you might find that, you know, the food was the thing that kind of helped them at that time. But in the past, they've had other coping strategies. So things like, as I mentioned, substance use, might be things like self-harm as well. That's often a very kind of impulsive coping mechanism that people tend to have. And I think, you know, trying to be able to think with them about, again, what was happening before, what's happening now, what's happening when the eating disorder is getting better. That really helps us to assess, is there something else going on that might need treatment?
Amazing. Thank you.
Thank you.
We'd love to go back to the topic we started on around medication and how you prescribe medication, whether you decide that it's the right option for somebody, how it can be helpful for them in eating disorder treatment. I have actually been on and off medication. I started it during my recovery. It took a long time to convince me to go on it. I found it a difficult decision to make, but it was actually so helpful when I took it. And then, like I said, like on and off since then, when I've had difficult times, I have actually gone back to it. So yeah, how do you find it to be helpful, and how do you make decisions around it?
Yeah. So I'll talk about physical health medication, because I think that's a part that people forget. And then we'll talk about the psychiatric medications. So often, you know, when we're doing our assessment, we've obviously got to think about, is there anything in terms of their physical health? Do they need any additional vitamins, thiamine, which is really important because that can really contribute to kind of like your neural connections and things like that. So you want to make sure that you're not low in B12 and thiamine. And sometimes for people who haven't been having their period for a long time, it might be that they need some hormonal support, like the pill, or maybe bisphosphonates, which will help in terms of kind of bone density, right? So there are various physical health medications, physical health tests, and things that would be important. In terms of psychiatric medication, in all my practice, whether it's eating disorders or anything else, it's never the first line. Okay, so it's never the first choice. And that's because we know that therapies are helpful. And as long as they're kind of evidence-based therapies, and there's a good therapeutic relationship, that actually that is probably, I always use this, I don't know the exact numbers, but I will always say to clients that, therapies are probably like 60% helpful, and medication might be like sort of 30-40% helpful in terms of getting recovery. So it's never the first line. And also we need to kind of think about how well is it going to work in someone who might be undernourished, right? So if you're starting a medication in someone that's undernourished, their experience of it is going to be quite different compared to if they were starting it when they're nourished, because one, it's even less effective at low weight. And you also experience more side effects. So those are things that we need to think about. Now, that's not to say that for patients that I'm seeing quite early on that we don't start the medication, because we look at the risks versus the benefits. So if there is a client who is really distressed, who it's been really difficult to sort of get them onto a meal plan, parents are really struggling to be able to feed their child. There's a lot of sort of upset and low mood and anxiety around meal times, a lot of fear, and we're kind of stuck. We're not getting anywhere. Then that would be something that we would need to treat to be able to help the client, because there's just so much distress. So in those situations, and in situations where maybe they've tried therapy for a while and things remain quite stuck in therapy, it can be that extra thing where the therapy and the medication together help you to kind of unstuck something and hopefully get further on in your recovery. So I would say those are the main times that we would consider medication. Oh, and probably just to say, if there's underlying comorbidities, anxiety, depression, particularly if the depression is quite severe, if there's self-harm, suicidal thoughts, again, that might be a time that you consider medication in addition to the psychotherapy or the psychology.
Interesting. Dr. Teizeem, how do you choose which medication is the right medication? I'm guessing there are a range, and how do you determine that? What kind of side effects could people experience?
Yeah, so the common medications that we tend to use in eating disorders would be antidepressant medication, which works on low mood and anxiety, and then antipsychotic medication at low doses. So the reason that we use the antipsychotic medication for low doses, it's not that the person is hallucinating or that they have psychosis, is that it actually helps manage the distress and the levels of anxiety. And if we think about it, in some cases, some of the thoughts that people have in eating disorders can be to like an almost, I wouldn't say they're not delusional, but it can be almost to that sort of, what we call them is overvalued ideas. So it's to that extent. So, I've seen clients where they can't brush their teeth because they're worried about calories, or they're unable to sit next to someone who's eating because they're worried about transfer of calories. So that, I wouldn't say that's delusional, but it's an overvalued idea. And the preoccupation is so significant that actually a low dose of antipsychotic medication can really help in those cases. And it just reduces the distress. It helps them to be able to get onto, a good enough meal plan that's going to help them with their recovery.
Do you find resistance to people taking it, though, because they almost don't want to lose that thought? As in, because they believe it so much, it's almost scary to think they wouldn't have the thought. Do you know what I mean? Like almost the thought's protecting them in some way. So if I take this medication, what if it stops me doing the thing I need to do to protect myself?
Yeah, absolutely. I think that's one of the biggest fears is around losing that control. and the function that we talked about, the function of the eating disorder. But if they take the medication, it might help them, and then that might mean that they lose the function that the eating disorder is playing. So that can be really scary, and I understand that, and I have those really transparent conversations with clients around, the risks and the benefits. What are, what's it going to look like if we remain stuck here? Where are you going to be in a year's time? Are we going to be able to get you to university? Are you going to be able to start enjoying your childhood with your friends and going to parties and enjoying yourself? So we have those conversations. And I think, there's the fear. It really depends, because some people also don't have any insight that they have an eating disorder in the first place. So they might feel that actually, yeah, I'm overweight. I don't care what anybody tells me. I see myself as overweight. I don't have a problem. They sort of minimize maybe the physical risk often. And so their insight can be really poor as well. So then, why take the medication? And then other people feel that, if they take the medication, maybe it's a failure. And in two regards. One, so we can imagine that people with eating disorders, some of them will be quite perfectionistic. And so, there's that sense of, I should be able to do this on my own. I don't need the help of medication. I can, this is something, it's a challenge. I can do it on my own. I can get better on my own. I don't need the help. So that's one part of it. The other part of it is that actually exactly that kind of fear of, what if I take the medication and something changes? And I think sometimes people will then feel like, okay, not only am I failing, but I'm by taking the medication, but I'm also failing at how good I was at the eating disorder. So I think, yeah, it's really important to have all of these conversations and try and really think about, because often, children, but also parents will say that they don't want to put children on medication, even when it might be quite necessary. So having those open conversations, trying to really think about what's the reason that you're saying no, what's the hesitation. Sometimes families have had bad experiences on different medications, and they have a history of other people, uncles, grandparents who have gone on medication and maybe they've not responded well. And it could be a different disorder completely, a different type of medication completely, but actually what they see is, we can talk about side effects of what they feel is that person's personality has changed in some way by going onto the medication.
Yeah.
So that's a big thing.
They're losing more of their child. They already feel like so much of their child is gone. But now with the medication, even more so. And
that's why the monitoring is so important, because it is really a fine balance between the risks and so the side effects and the benefits. We want the medication to be helping the young person. We don't want them to lose their personality. We don't want them to have side effects that aren't manageable. And so if you're frequently going for reviews with the psychiatrist and you're monitored and you're talking about all of these things, then the way I would work is, well, I think, okay, do we need to reduce the dose? Do we need to think about a different type of medication? Because I don't want people taking medication that's not helping them. So I think it does really matter to have a good experience of taking the medication. And Megan, maybe you can sort of say a little bit more about, because you said that you've been on and off the medication because it has helped you.
Yeah, I don't even know that I've ever shared this before, but I feel like there's a bit of a taboo around medication as well. Certainly when it was first suggested to me, I was like, I don't need medication. I was very offended. I've been suggested. And also maybe even with you're saying the family thing of there's been a bad experience. Also, if there's been no experience of it in your family, you're almost we're not a family that. I feel very arrogant saying that, but if nobody else has taken, it's not normalized. It's not a thing you'd think of, kind of thing. So I maybe had a bit of that. And also I was just very scared to take it. I felt very protective of my eating disorder and very scared of what would happen. I wanted to feel in control in my brain, which I felt like the eating disorder gave me at a lot of cost, but and I really worried about losing that. But when I did go on it, that wasn't the experience I had at all. And I think, like you're saying, I took it because I was stuck. So I kind of, in some ways, knew I wanted to get better, I wanted things to be better. I wanted to be able to join in with life more, that kind of thing. But when it came to making the change, I couldn't do it. And I felt really, really anxious trying to do it. And I think it just helped with that. Like my anxiety didn't fly. It kind of like, I still felt like myself. I could still think on both sides, but without like losing control of my anxiety whilst I was doing it. So I feel like it was used to help me do what I already kind of wanted to do, not 100%, but I kind of wanted to do it. I just couldn't. And it helped me, it kind of helped me with, I still felt like I was choosing the action. It just helped me to make that choice.
It was a tool. It's kind of, it helped maybe take the edge of the anxiety off a little bit in a way.
Yeah, it was still there though. It's not like it took it away at all.
Completely.
I just could, I don't know, I could think more, like I had more,
More options?
I could more make a decision. It was still me making the decision. It didn't change, it didn't even really change how I felt about it. I was still scared, that kind of thing. I don't know. I don't know if that's making sense that I'm saying that.
It does. It does. So just a little bit of more of a broader view, maybe like more options, slightly more ability. But then I
Yeah.
guess then that allowed you to collect up more evidence that you are able to do it and that your life does open up. And yeah, so it was a tool that helped you to be able to collect evidence for yourself, kind of for
Yeah,
you
yeah.
to
Yeah.
recover.
And it definitely did help because it did help me to make actions that did move me towards like a happier,
Where
more
you want to be.
fulfilling, more balanced life, you know?
It was
Yeah.
interesting what you said about we're not a family that takes medication. So it's I think a lot of
Psychiatry.
no.
I
Well, I
love
mean,
that. That's
but
so
I
cool. I'd love to be able to say that, Dr. Teizeem. It was really interesting what you said about that. I'm a wannabe
Oh,
psychiatrist. That's
such a
so cool.
reveal.
Sorry, I actually I want to hear the rest of this. This is great.
so I say it's interesting because actually that is where a lot of families come from. So there's a lot of fear, right? Because it's not something that's been done before. But actually, if your child had asthma, would you not take the inhaler? And the inhaler might also, if you need to take steroids for something, you've got eczema, you need to take steroids. Steroids have side effects. They have long-term side effects, right? Similar side effects to what other medications might have. But we're more likely to be okay to take these types of medications compared to taking medications for our mental health. And I think, I mean, it just feeds into the kind of disparity between mental health and
True.
physical health. And I understand it. Even I am very balanced as a psychiatrist. I'm never pushing medication, so I do understand it because it's an unknown. There's worries about the side effects, but when it helps, it really, really helps.
Yeah,
and people will often. I don't hear many people who will say when it's helped, I wish I didn't take it.
yeah. Interesting. Yeah. Yeah, I can see that as well because it's like it's your brain that you're dealing with. Like when it's medication for your body, it's like a physical, like you're looking down at your body, but when it's inside your own head, that's quite yeah.
Yeah.
Yeah. Also, interestingly, my family are all medical. So I feel like we're even less into medicine, being a medical, I don't know, different topic,
It's
but
like
yeah.
doctors don't go and see
Yeah.
doctors. We're all
Never. Take a paracetamol, you'll be fine, honey.
Yeah, same. My dad's a doctor too, and similar situation. Yeah, it
Yeah.
was. Yeah, it's funny, isn't it? I think we've got through most of our questions. Do you think? I was just thinking one thing because I didn't think about it from the medical side. Do you think you could talk about the impact on the body? Because I'm just thinking so many people think because all their blood tests are okay and nothing is showing up or their heart seems to be ticking away that they're actually okay. Is that would that be an okay thing to talk
Yeah,
about?
yeah, absolutely. So I think I mentioned before that it affects all systems of the brain, right? So and differently. So if we're thinking about anorexia compared to bulimia and some of the different behaviors related to that, right? So if we're using laxatives or if we're purging, regularly vomiting, that kind of thing. And some of those things, like you just said, the brain, right? You can't really see it. You can't see the broken hand or the rash, right? So often you won't be able to see the effect that it's having, and sometimes you might not see the effects it's having until it gets to a stage where actually it really then is quite significant, or sometimes is too late. So we don't notice changes in our potassium and our sodium levels, or our calcium and our phosphate levels, right? That's not something that we would know unless we did a blood test. And sometimes those blood tests will even come back positive 1 week, and okay 1 week, and then the next week, with the same behaviors, etc., that they might actually be low, and it might mean that you're having problems with your heart, maybe pain, maybe arrhythmias, dizziness, low blood pressure, low heart rate is one of the things that we see, and then we really realize that actually this is really causing strain on the heart. Other aspects are, things like losing period. So that is something that often people will, might get to a point where people lose their period, and for some that probably sounds great. Yeah, I don't have to have my period. It's such an annoyance anyway. But actually, we don't quite fully understand the effect that it can then have on the rest of our system. So particularly young people under the age of 18 who lose their period, and if it's been lost for 6 months, a year or more, often that will affect their bone density. And then that means that you're left with kind of weak bones going into your adulthood. You're more at risk of having fractures. You're more at risk of having osteoporosis at a younger age, which shouldn't be happening. Osteoporosis is something that happens postmenopausally in kind of like older women, for instance, right? It shouldn't be happening at a younger age. And so these things, it's really hard to hold on to, especially when we talk to clients about it, because they're thinking, well, actually, this is something about, when I'm in my 40s and 50s. I'm 16 right now. I'm not really worried about that. That's not a motivation for me to get better. I'll tell you one thing that people do really worry about: hair loss. So that is something that is a big motivator. People don't like losing hair. People often find that sometimes their skin is quite different, quite dry, maybe developing acne. Those types of things. So those more kind of cosmetic, can I say, or things that you can actually see.
Or immediate.
Immediate things are the things that people feel more motivated in order to kind of try and get better physically. I don't know if I went on a tangent. Did I answer the question?
Yeah, that was so interesting and so helpful to hear, because I think that's the thing, is like, even if all of your results are okay, it doesn't mean that your body isn't in need of getting better or healing. And I think as well, something that dawned on me when you were explaining how long your training was, even post qualification of being a doctor, to understand fully the concept of an eating disorder. Because I think sometimes people will go to their own GP and their GP will say, wow, you're great. And like me personally, I had a low blood pressure, and they're like, oh, that means you're so healthy. You've got a blood pressure like an athlete. And I was like, well, that means I'm fine. I don't need to get better. Actually, I'm healthier than all these people that are telling me I need to get better. But I think the fact that actually you've had so much more training to understand what an eating disorder is means that sometimes you can question and wonder, like, not, undermining doctors at all, but like, it doesn't mean just because somebody hasn't seen your eating disorder that it isn't valid, and you absolutely deserve to get better.
Absolutely. And we will often try and work with like family doctors and pediatricians that have a background in eating disorders or see lots of eating disorder clients, because they then know and understand what the results mean, right? So you could go to, and this has happened on numerous occasions, we've sent people for bloods. Bloods are back okay, ECG is okay, blood pressure is okay, heart rate is okay. But what the doctor sort of says, yep, your weight is fine, height is okay, we're all good. What they might not have the context of is that person has lost 10 kilos in the past 2 months, right? So, and they might also not quite grasp that person is going home and still only having, 500 calories a day and exercising excessively. So when you don't have that as a picture, and you interpret the blood tests just because the blood, it's a snapshot, those investigations, but without the context of what's been going on, that can be quite dangerous. And so and it does give the wrong messages to the young person or even the adult with the eating disorder, because actually, none of us know in terms of the full context unless we're told the full context.
Absolutely. So interesting.
Yeah,
Thank
yeah.
you.
Well, as in you've got to take behaviors into account, emotional state, what's it like to live in your brain, your thinking, your relationship to food and people. Also, I guess everybody's body responds differently as well. Like one person might not experience hair loss, or one person might not experience period loss, or one person might come back with great blood tests, but like doesn't mean there's not a problem there, kind of thing.
And we want to remember this psychological impact too. So again, things we can't see. So I will often show my clients a picture that I have of a brain, like an MRI of a brain, of somebody who doesn't have an eating disorder compared to somebody who does. And what actually happens to the brain? It shrinks, right? So there's less volume, and we know that because of the studies, but we also know that because of the psychological effects that we see, the increased depression, increased anxiety, preoccupation with eating, something called the Minnesota trial that sort of looked at all of these things. So what we can see is we can see that difference. And what we know is that actually the psychological impact doesn't get better until you physically get well. So once you're physically better, the psychological recovery tends to happen. And even then, it's a little bit delayed. So usually it will be somewhere around like 3 to 6 months before you psychologically recover after your physical recovery. Wow. So actually, you can't ignore the physical recovery. You can't, and often, parents will say to us, "We'll just give our child the therapy," and we say, "Yes, we can do both, but we have to do the physical recovery because otherwise, the therapy can sometimes be pointless because the young person isn't cognitively there, isn't able to do the work."
Yeah.
Like you said, Meg, that, the thinking is just not clear, right? And then something switches and you're able to make decisions again. You're able to think more clearly. And so the experience of someone who's undernourished, who goes through therapy, is completely different compared to the experience of someone who is well nourished going through therapy.
That's interesting. Yeah, it makes sense. And I think a lot of therapists do have a threshold to not go under that certain BMI because of that reason, because they're just unable to get through to that young person or adult with the eating disorder.
Yeah, absolutely.
This has been amazing. Thank you so much, Teizeem. Where can people find you?
So I work at Sage Clinics in downtown Dubai. We have a great website with lots of information and actually some free supports in terms of like blogs and articles that have been written around eating disorders. We also have our social media page, which has lots of videos. You can get to know the clinicians. So you can find me at Sage Clinics in Dubai.
And you work online, Dr. Teizeem, if somebody is not based in the UAE, you do see clients online as well?
Yeah, absolutely. So we'll assess kind of the risk of seeing clients online. But I often have clients who are either going to university or traveling and need to be seen online. So we do online consults. We have a multidisciplinary team. We've got a couple of psychologists, a dietitian, and myself. So we all work together. We make sure that we're sort of looking at the patient as a whole and the family as a whole. And we see, I've spoken mostly about children because that's my specialism, but we see across the lifespan, young children, adolescents, adults, and even older adults.
Amazing. Thank you. Incredible clinic. And thank you so much for this conversation. It's going to be so helpful to so many.
You're so welcome.
Thank you so much, Dr. Teizeem.